Thank you, Madam Chair. Thank you, Doctor, for being here. Thank you for your lifetime work in this field. I want to talk to you a little bit about, and very much appreciate the evidence-based approach. We've had success in a bipartisan way on criminal justice reform. We've had people like the Heritage folks agree that evidence-based research policies can work and they're effective. And they clearly work when it comes to substance abuse. Only 30 million Americans who have substance abuse problems, almost 70% of them say they're either in recovery or have recovered. For those of us who are familiar with recovery, there's certainly an argument to be made. You're always in recovery once you have become addicted. One of my frustrations, Doctor, is, and I'm sure it is yours as well, the scale of this country, your institution. I was at an event this Sunday for a sober living nonprofit that I've been involved with since I was in local government 30 years. It was myself and the presiding judge of our drug court, who was a Republican nominee. And we were talking about, ironically, the last comments about hope and the hope of having programs like that at a community level where users and families, users of the services, addicted people, can see them work because of the evidence-based research. So the frustration is getting the federal government to be in a role of, from my perspective, identifying those programs that work and then incentivizing investments in those programs at a community level. Could you speak to that, both your frustrations and the successes? I look at places like Johns Hopkins and UCSF here where I live, where the exponential research and understanding of addiction and neuroscience is so wonderful, but then deploying that to the communities that need it is so frustrating.
Thank you, Congressman. I think it's an important piece to understand at least 2/3 of people that are incarcerated have a diagnosis of substance use disorder or addiction. Therefore, it's important, first of all, to think about all the programs that could do a pre-arrest diversion, like deflection programs. We've just put out a state model law that tries to get people, both public safety and public health communities, to work together to get people the help they need in lieu of arrest and incarceration. It saves money, it's common sense. Second, drug courts. We want to make sure that before either pretrial diversion, drug courts, and other aspects like that, we have robust training the strategy calls for, and ensuring that people have the opportunity for non-violent crimes to move on to make sure that it happens. Treatment for people incarcerated is critical, and we're doing that because people become more productive. The death rates decline significantly, as we've seen in states like Rhode Island, when we can treat people. And recidivism and all those costs go down as well. And then re-entry. It's important to make sure that when people are ready to re-enter the society, we get them the tools they need to be successful. And that's where treatment, continuing, and community connection become important. And then recovery support services, understanding that recovery is not about a treatment only, but it's about all the support that individual needs with their health, with their home, with their community, and with their purpose in life, to make sure that they have all of those surrounding services and supports to make them successful across the lifetime.
We'll follow up on that, having had multiple discussions with Secretary Walsh, and a member of the Education and Labor Committee and chair of that committee's Health, Employment, Labor, and Pension Subcommittee, and with Javier Becerra, a good friend here, from how do we coordinate those services? So again, at the community level, years ago, I had a conversation when I was in the legislature, and we were dealing with both criminal justice reform that's been successful here in California and the ACA. I had the warden of San Quentin tell me, why are you surprised that we release people from here back into your district in Richmond, California, or Oakland, and they're back here within a month when we only give them $200 and say good luck? So how are we coordinating those services at the federal level and at the state level?
At a federal level, Congressman, it's important for us to be working together, and that's where ONDC comes in with this strategy, because it allows us to work with health and human services, with labor, with HRSA, with making sure that we have the addiction, both recovery-ready workforce as well, but also recovery-ready employers and employment places that allow that to happen. So it's a matter of coordination, and that's exactly what we're doing by bringing all the 18 drug control budget agencies together and work on it collectively. the state level, I'm proud of when I talk to leaders like Governor Sununu in New Hampshire, who was actually leading recovery-ready workforce, recovery-ready workplaces. I visited him, and I was happy to see how far we're moving when we decide that this is the right thing to do because it makes sense. And there are governors across the state, across the country, that are actually moving to understand it's the cost-effective. Well, there's 23 million Americans that the president called out in State of the Union speech that are on path to recovery. We need to support them and do everything we can to provide them the resources.
Thank you, Doctor. Public health is public safety, right? I yield back.
Yes, sir. Thank you.
Representative Comer, you are now recognized.
Thank you, Madam Chair. Dr. Gupta,